Hello, everyone, and welcome to today's webinar. I'm here with Dr. Weiner. I wanted to let everyone know if you do have any questions today, please submit them through the chat. We will have some time at the end to go over any questions you have for Dr. Weiner. We'll be monitoring that, and if we can answer any in the meantime, we will do so. But I'm pleased to welcome Dr. Andrew Weiner. He's a board certified urologist with over 20 years of experience. His clinical interests include the treatment of urologic malignancies and studying the impact of cancer in an underserved population that typically is underrepresented in publications. Dr. Weiner received his doctorate of medicine at SUNY Stony Brook School of Medicine. Following his urology residency at Downstate, he then moved across the East River for a 2-year fellowship in urologic oncology at Memorial Sloan Kettering Medical Center. Cancer Center, sorry. He is passionate about mentoring the next generation of physicians and urologists. He is the chief of urology at Kings County Hospital Center and associate professor at SUNY Downstate School of Medicine. Welcome, Dr. Weiner.
Thanks so much. And welcome everybody to the webinar tonight. I know you've all either finished a long day at work or are getting ready to settle in at the end of the night. So whether you're on the West Coast, Midwest, or East Coast, thank you so much for joining. I see a couple familiar names on the list, and welcome and thanks for joining also. So tonight we're going to talk about how to use and leverage the resources that we have available to us in low and favorable intermediate risk prostate cancer to achieve what we call the patient trifecta. So full disclosure, I am a practicing urologist and I am in the trenches every day, just like you guys are, and I'm taking care of these prostate cancer patients. And I also often find myself a little bit frustrated and confused as to what's out there, what's available, what should we be doing. And I'd like to try and simplify things if I can, and hopefully not confuse you, with the latest literature and how to really hone in what we have available to give the patient the best outcomes possible. So, without further ado, I would like to start with a little bit of a thought exercise here. So, I'm going to harness my inner Tom Cruise here when I say, you have a patient that has prostate cancer, and you have to tell that patient that despite their prostate cancer, you will control that cancer, preserve their erectile function, and also preserve their urinary continence. So we often find ourselves in this exact position with low and favorable intermediate risk prostate cancer in particular. And what I would like to focus on is what we call the prostate cancer trifecta, which is trying to control all three of these things. So what are the main challenges in managing low and favorable intermediate risk prostate cancer? Well, it's a very complex disease process, actually. I mean, you get a diagnosis of cancer, and a lot of times we want to say we're relieved, right? You have grade group 1 or low volume grade group 2. This is great news. And I often frame it that way. But the reality is they have multiple treatment options. They have active surveillance, focal therapy, surgical intervention, and radiation. We have to talk about oncologic control versus quality of life because each one of these things has quality of life and oncologic implications. We have to talk about the risk of disease progression versus treatment side effects. And we really have to individualize the approach based on the patient's disease parameters. Do they have high volume grade group 1 versus very low volume grade group 1? Is the grade group 1 with a PSA of 20? What's the patient's overall health? What's their 5 and 10-year disease or life expectancy? Are these patients comorbid to the point where they may not make it 5 years and they would likely pass from something else other than their disease? And then also we have to take into account the patient's preferences. Are they very anxious about having a cancer diagnosis, and this is the number one most important thing that they will hone in on for the rest of their life? Or are they extremely focused on their erectile function or their urinary continence? Every patient's a little bit different. We have to talk about active surveillance versus immediate treatment in these patients. So active surveillance, as we know, avoids overtreatment, but it leaves many patients as well as doctors with the psychological burden of potential disease progression and uncertainty. And then we have to talk about immediate treatment, which is it addresses the concern about disease progression, but it may treat unnecessary patients and expose them to quality of life changes, leading to what many of us have seen is decisional regret, both on the physician and the patient side. So that can often lead us as urologists or practitioners and the patients scratching our heads saying, how do we proceed? Or in many cases, ready to scream and pull our hair out. But the reality is that in 2026, I think most of us recognize that we're starting to change the paradigm with low and favorable intermediate risk prostate cancer and really reset that default towards active surveillance as opposed to having active surveillance be a secondary or tertiary option. Peter Carroll from UCSF, he presented at the 2021 AUA. If you look on the right side of this screen here, there are three columns. One is for low, favorable, and high risk. Sorry, low, intermediate, and high risk. The third from the right, you're going to see that's low risk. And what he's pointing out here is that in 2018, a patient with low risk disease, only 55% of urologists were going to be considering utilizing active surveillance for that patient. Now, that's a remarkable improvement over 10 years from 2008. And since 2018, that number has since increased. And I'll show you some data in a second. But we still have a significant gap and I think room to improve there. It's less than it should have been in 2018 and continues to be less than it should be now. In July of 25, just a few months ago, there was a publication in JAMA Oncology from Dan Lynn's group, and I think it was a really important publication. And I want to highlight a couple of things here. So there's been a trend in the field towards trying to take what we've been doing and take it even further. So we've been trying to move towards active surveillance for grade group 1 and low and favorable grade group 2s. But now there's a trend towards trying to suggest that grade group 1 shouldn't even be considered cancer at all. I'm not here to say that that is a fallacy, but what I would say, and I would caution the group, is to understand that not all grade group 1 is the same. So there's a tremendous amount of variety within grade group 1 and favorable grade group 2. So this study was a SEER study that looked at 117,000 men with grade group 1 prostate cancer. And what they did was they divided it into four categories based on NCCN risk. A low risk grade group 1, a favorable intermediate risk grade group 1, unfavorable, and high risk grade group 1. And what you see in the figure here on the right are trends in how these patients have been treated over time from 2010 to 2020. And what is nicely shown here is that from 2010 to 2020, there's a significant uptick in the utilization of active surveillance for low risk grade group 1, which is excellent. We're seeing close to 70% in this category, which is even higher than what Peter Carroll showed. When you have favorable intermediate risk grade group 1 and into high risk grade group 1, you can start to see that the utilization of active surveillance decreases and immediate intervention, either radiation or surgery, starts to increase. And immediate surgery or radiation are in the blue and orange lines here. And the black line, again, is active surveillance. So this is good. This is what we want to see. We want to see people, using what they have available, understanding that a high risk grade group 1 is not the same as a low risk grade group 1. But I think that it's really important to make sure you integrate that into your treatment strategy and your paradigm. And then they went on to risk stratify these patients even further. And this is a survival curve model. And what they found is that the low risk grade group 1s, over 120 months, there's still a significant portion of these patients that are succumbing to prostate cancer. So this is the cumulative incidence of prostate cancer death. So when it rises, that's a suggestion that there is some degree or some risk of prostate cancer death. And what we need to understand as urologists is which patients can we follow on active surveillance or which are the ones that we need to intervene on. And I don't think it's fair to say that all grade group 1s are equal. And that's what the point that I'm trying to make here. Furthermore, if you look across active surveillance series from Toronto, Cleveland Clinic, Hopkins, Europe, the UK and Sweden in the Gothenburg trial, you can see here that cancer mortality and metastases still range from 0 to 10% in the various series. So these are active surveillance series, and they have a tremendous amount of variety in terms of their long-term outcomes. And I think that this really begs the importance of utilizing all of your tools to decide and determine who is an accurate candidate for active surveillance. So we have the digital rectal exam, we have the PSA, where gold standard now is to utilize MRI. We perform the biopsy, likely MRI targeted, and then we have gene expression panels and profiles that we can utilize to really harness, to complete the story. And I think this, to me, is where genomic biomarkers shine. So, in my opinion, there's three reasons to harness the utilization of genomic biomarkers. One, it's to improve the risk stratification beyond just the basic clinical factors. So you can see here that, it provides biological risk information. It can help us determine which are the more aggressive tumor types, which are the wolf in the sheep's clothing, and which are indolent versus potentially aggressive. Furthermore, if we take that a step further, we can better select patients for active surveillance. So we're going to be in the 0 to 1% in long-term mets and death, as opposed to the closer to 10% that we saw in some of those active surveillance series. So you can select patients for active surveillance more accurately instead of guessing. And then third, you can personalize the way you follow these patients on active surveillance. So it can inform how often you're checking PSAs, how soon you're going to get an MRI, and whether or not you're going to repeat the biopsy sooner rather than later. So if you get a genomic score that's very reassuring, you might be able to hold off on some of these studies a little bit longer than you would have before. So in this space, talking about genomic biomarkers for selecting an active surveillance candidate, there are three that are currently on the market. And I would say that if you were to ask me to speak in a panel, I could very much make a distinction between all three of these things, but I don't think that a lot of practitioners can accurately tell the difference between GPS, Decipher, and Prolaris. And if we're talking about the patient trifecta, which again is cancer control, continence, and erectile function, and you're trying to select a patient that you want to operate on versus maybe watch and maintain all of those potency and continence and still control their cancer, you want a test that's going to tell you the most important information, which is prediction of adverse pathology. So Prolaris doesn't even predict adverse pathology at all. So it's not even part of the prediction model that they report out. Decipher, full disclosure, I use some of these biomarkers for other indications, but when we're talking about low and favorable intermediate risk disease, and you're talking about active surveillance, Decipher really backdoored their way into this space. It wasn't initially designed for this indication. It was really post-prostatectomy, escalation or de-escalation of ADT. And we can see that in their endpoint that they used for adverse pathology, which is T3B or seminal vesicle invasion or higher. Once it's reached T3B, in my opinion, that patient needs adjuvant radiation plus hormones. So if you're a surgeon and you want to operate for cure, and you're sitting there and a patient has only a biopsy information, you're trying to predict if they're active surveillance or treatment, T3B is too late. That's way too late. The patient has already got potential micromets or locally advanced disease. So this is, really one of the main reasons that I select GPS for this patient population. Again, low and favorable intermediate risk disease who are considering active surveillance. They use an adverse pathology definition of T3A or extracapsular extension, and they have long-term data, and it's based on prostate biopsies. So let's go into that a little bit further here. So it's GPS, or the genomic prostate score, formerly known as Oncotype DX. And I love this picture. It's got a black man on it. And, this is the patient population that I'm taking care of in central Brooklyn. So it's near and dear to my heart. And I'm happy that the company chose to use that as their marquee, model. But why GPS? Really, endpoints do matter. As I mentioned, the definition of adverse pathology matters. Not all tests were designed for the active surveillance space. There's long-term data, up to 20 years for GPS. The tissue requirements are less than 5 nanograms, which is compared to 25 nanograms, or 5 times what GPS requires. That's for Decipher, and is very affordable for patients. I've never had a patient, even in my patient population, say they can't afford it or complain about not being able to access it. So this is how the test was designed. This is GPS. Um, why am I showing you this? Well, I want to show this because they started with 727 prostate cancer genes agnostically, and then they whittled it down to 288 genes from the whole mount prostates. That's where Decipher stopped. Okay, so they stopped at the whole mount prostate and didn't whittle it down to a biopsy sample. And in my opinion, that's a bias. Once the prostate is out, there was a reason the prostate was out, and so there's a sampling bias there. But if you take it a step further, which is what the GPS scientists did, and test it on biopsy samples, now we're comparing apples to apples. So when you have a patient, Mr. Jones sitting in front of you who's got a biopsy only, and you're trying to predict into the future, you want to do that based on something, that is accurate and representative of the disease state that you're working with right there and then. So again, GPS uses an adverse pathology definition of T3A disease. Now, up to 70% of T3A disease can be contained and controlled with surgery still. So as we know, you can get negative margins and cure these patients even with T3A disease. But T3B disease is a very different story. And so that's why, again, the adverse pathology definition is so incredibly important. Just to summarize again, adverse pathology really does matter. T3A is still local. T3B is often associated with micromets or even systemic disease. Vip Patel down in Florida, who we heard a webinar from a couple of weeks ago, he published this study a few years back on his patient population, 750 cases, who underwent Oncotype and then radical prostatectomy. And what they found was that Oncotype, or GPS now, really can predict all these markers and these pathologic findings that are germane to, a urologic surgeon or somebody who's taking care of prostate cancer patients in the local and low-grade and favorable intermediate risk disease. So you can see here for every quartile of GPS, you're increasing the risk of extraprostatic extension, seminal vesicle invasion, and tumor margins, positive tumor margins. This study actually very much helps me in determining not just who's a surgical candidate, but when I'm going to do some nerve sparing, how close I'm going to spare the nerves. So I'm using GPS and MRI and the PSA and all of these things are incredibly valuable when determining how to treat a patient. We know that MRI helps with surgical planning. It can identify tumor invasion in the neurovascular bundle. So this is a meta-analysis, another one, and another one. We know that it can help. Okay, so I'm very much a proponent of MRI. I find it incredibly valuable, and we should be using it routinely. But when you look at GPS in comparison to MRI and how it stacks up, this was a study back in 2018 out of the Journal of Urology. They performed a multivariable analysis trying to determine predictors of adverse pathology at the time of surgery. They took multiple different variables, including PSA, including MRI PIRAD score, including Gleason grade, and GPS, and the only things that were statistically significant were the GPS score and the biopsy Gleason score. The MRI actually wasn't predictive in terms of determining adverse pathology. So do I use it for helping me nerve spare and do some surgical planning? Absolutely. But you can see here the power of GPS in determining adverse pathology and deciding when to operate and not just operate willy-nilly on everybody. So we want a test that's going to help us change our management, right? You don't just order a test to order a test. This was day one of medical school or whatever training you've gone through to get to where you are. You learn that if you're going to order a test, it should help change your management. So I ordered the test for a number of years, and in May of 2022, we had looked back at just a small cohort, 63 men of our own patients. All of them were African American or Afro-Caribbean men who had underwent biopsy at our institution. And what we found is that 44% had a change to a higher risk designation based on the GPS result, and 20% actually had a lower risk designation based on the GPS result. So it's a little bit of a confusing schematic here, but if you look on the left side, this is where they start in terms of their NCCN risk stratification. And then after the GPS is included, you can see where they end up. So there's a tremendous amount of movement from low risk to favorable intermediate risk, low risk stays, or low risk to very low risk. And I think what that shows me is that just pathology and just MRI are not enough. So for me, this was a really important study, and it actually helped, it solidified my protocols and my clinical care pathways. But don't believe me. Let's look at a number of large studies that were done across the country from the West Coast to the East Coast. And you can see here that GPS consistently increased the active surveillance use among patients. So you can see here active surveillance rates without using GPS testing is in gray. And then in orange, you can see with GPS, it actually increased the use of active surveillance. So it really did change the management in these patients, in a favorable direction. You wanted to really support, hopefully, what you're doing. So again, just to show that comparative slide, there are other options available, but I really do feel strongly that GPS was designed for this space. It's got the right pathologic endpoints. It's got 20 years of follow-up. And so you can sort of get blindly pushed into using one type of test for all comers and all disease states. But the reality is that's not necessarily the best thing for the patient because each of these tests were designed differently for different disease states. So understanding what you're ordering and why you're ordering it is really important. So I'm going to go through a couple of real world examples of my own patients that, in different ways, GPS really helped me hone in on delivering that patient, the prostate cancer trifecta. So this was a 64-year-old African American gentleman with a PSA of 6.3, a T1 lesion, and he had an MRI PIRADS 3 lesion, and we found grade group 2 in 2 out of 12 cores. I ran a GPS on this patient because I was considering for active surveillance, but his GPS was 38 and he had a risk of non-organ confined disease at 34%. So just to pause for a moment, I want to highlight my clinical care pathway. So when I have a patient that comes to me in this regard, this is my schematic. Now, you're looking at this and your mind is going like, boo, 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 I can't follow this. It's a very busy slide. And I'm not going to go into it in detail, but what I can tell you is that it's extraordinarily helpful when level setting for my APPs and for my residents so that we're all on the same page. And I would strongly encourage you to also create your own clinical care pathway. So in this pathway, we have an elevated PSA, and we can use the ExoDx test. We have a positive biopsy, and we can use the GPS test. We have a negative biopsy, and we can use the Confirm MDX test. A lot of tools available within MDX's portfolio for this clinical care pathway. But how do I use GPS? So I order it for all biopsies that return as low or favorable intermediate risk disease. So prior to starting active surveillance, I order it. And I want to make sure that the tumor is not biologically discordant with the pathology. And I generally use 30 as a cutoff for reassuring versus concerning. Now, I didn't say I use 30 as a cutoff for intervening versus non-intervening. I said reassuring versus concerning. And why? Because it's much more nuanced than that. So if it's above 30 and it's like 32 or 33 and the patient is 72, well, I might just follow that patient a little bit closer, but I don't necessarily need to intervene right away. So he's got grade group 1 and a GPS of 32. I might still watch that patient. But if he's 47 and he's got grade group 1 and a GPS of 32, then I might edge him towards intervention. So again, it's much more nuanced, but generally I use 30 as my cutoff for reassuring versus concerning. And yeah, I use it for subsequent biopsies as well when I do my restaging biopsies, because it can actually tell you if this is getting biologically more aggressive. So this patient ended up undergoing a radical prostatectomy, and he had grade group 3, which was higher than his grade group 2, which we initially had diagnosed. 30% of his prostate was involved. Unfortunately, we were able to get negative margins, and it was organ confined. And at 4 years follow-up, he remains with no evidence of disease, with full urinary control and 90 to 95% erectile function, and 100% with meds. So that's the trifecta, in my opinion. This is the perfect case. Now, clearly, I'm speaking to you on behalf of the company here, so we know that these are cherry picked, but this is a real life patient. And this really impacted how this patient was managed. And it's not an anomaly. This is one of many of my patients who look like this. So, case 2 was a patient who was anxious about active surveillance. When he had any diagnosis of prostate cancer, he wanted that thing out. He wanted it out. No questions, doc. I want it out. And I took a while to walk him off the ledge and walk him back. It was a 67-year-old gentleman with hypertension, glaucoma, BPH, relatively healthy. PSA went from 4.5 to 7. MRI showed PIRADS 3 lesion again. And we did a systematic biopsy, and we found that 4 out of the 12 cores had grade group 1. Now, many people would just proceed straight to active surveillance. And you wouldn't be wrong. And I'm not saying that you're wrong, but what I do feel strongly within my own, personal belief is that you have a test at your disposal to help you further elucidate what's going on in that tumor. Why not use it? Why not use it? Get some more information and then make a determination. So we ended up ordering a GPS test, and his GPS was 40. So he had he was in the moderate likelihood, again, 34% or extracapsular disease. And again, this is sort of the report. I tend not to look as much at the long-term mets and death and really focus in on the adverse pathology and adverse outcome. And that's why the topic of tonight's talk is the patient trifecta, because you're using this test to try and control his cancer, keep him potent, and keep him continent. So this is a patient that we can catch early before this thing mets out, and lo and behold, he undergoes a RALP. Again, believe me if you want, don't believe me if you don't want. I understand the skepticism of this being a cherry-picked case, but T3A disease and negative margins, which was great, and again, NED at 2 years with full urinary control. Now he had some baseline ED, but with PDE5s, he's satisfied with his erections. The third case is a patient who is eligible for active surveillance, but also with high anxiety. And this is a case when GPS supports or reassures a patient in order to sway them towards active surveillance. So, he's 62, Hispanic gentleman, PSA of 9, and we found that he had 2 out of 12 cores of grade group 1. And when we ran his GPS score, you can see here non-organ confined disease in 12%, and his overall GPS score was 15. So this is a patient who proceeded with active surveillance and remains on active surveillance to this day. So this was a guy with anxiety that I was able to then negotiate back off the ledge and support that with data from a biologic or genomic test that really reassured him. And the last case here, you could see is a patient who was a borderline candidate. So this was really up in the air. And I'm going to go through the case here, but just to jump to the chase here, he had grade group 2 disease, and he was really undecided, didn't really want to have an intervention, didn't really want to take the risk of active surveillance, needed advice. He really needed help, and this is where the tests shine. So it was a 67-year-old gentleman, hyperlipidemia, diabetes, and coronary artery disease. He has a couple of things under his belt here. And a DRE a little bit enlarged, and a PSA hovering around 5. PIRADS 3 again, that sort of waste bucket PIRADS 3 that we're seeing all the time. And he underwent a targeted biopsy, and we found grade group 2 disease in one of the cores and ASAP in one of the cores. So in my opinion, this is a candidate who's got coronary artery disease, diabetes, hypertension, hyperlipidemia, and one core of grade group 2 disease in 2% of the core. Great candidate for active surveillance. Really great candidate for active surveillance, in my opinion. But you get a GPS score to make sure, and look what he has. He's got the highest GPS score that I had seen yet. So still to this day, I don't think I have one that's higher than this. So he had a GPS of 51, and it puts him into the high likelihood of having adverse pathology and 50% of non-organ confined disease. So this kind of spooked me, actually. It doesn't mean that I won't use adverse surveillance in GG2, but it really reinforces the importance of utilizing all of the tools at your disposal. So this patient, he had some business to attend to abroad, and so I gave him a dose of Lupron, 22.5 milligrams, and he came back in 3 months, and then we did his prostatectomy, and he still, despite Lupron, had 50% pattern 4 disease, even though he had grade group 2 still, and fortunately, it stayed at T2 disease, and he's remained NED as well. So just to simplify things, again, this is the precision prostate cancer pathway from MDX, which is a little bit more streamlined than mine. But again, mine has a little bit more detail in there. Prostate cancer screening, you can get an exo, biopsy, it's negative, you can do a confirm. But in this case, in this topic, we're talking about low and favorable intermediate risk disease. And this is where GPS truly shines. And I think, and I hope that I've shown you why I use it, and how I use it, and how, for me, this can really benefit you as the provider and the patient when taking care of low and favorable intermediate risk disease. So just some key takeaways here tonight. Management of low and favorable intermediate risk prostate cancer is challenging, not can be, it is challenging. It's truly a balancing act. Cancer control versus quality of life, over-treatment versus under-treatment. And this is really the time as a provider to utilize and leverage all of your resources and hoping to aim for that prostate cancer trifecta. Personalized medicine, we often use as this hokey catchphrase, but I truly believe that we can do that for these patients. With imaging, genomic biomarkers, and clinical care pathways, you can reach that goal of giving that patient an individualized treatment care plan and ultimately reach that patient, prostate cancer trifecta. So that is all I have for tonight. Thank you so much. I would love to hear from the group, from the audience, any questions you have. It's one of my favorite parts of the night. So I love dialogue and conversation, and shoot me down, say there's something that I said was wrong, please let me know.
Yeah, please feel free, drop any questions you have in the chat. I have a couple for you here, Dr. Weiner, as well. We can start with that. I want to ask you this, and kind of cheating because we've already discussed this, which is kind of what led to the webinar today. But I want you to share what constitutes a success with you and your prostate cancer patients. That's kind of where we first started talking about the patient trifecta, and I think I'd love for you to share with the group.
So success for me is what's successful for the patient, and I think it's understanding what they need. First of all, they don't always know exactly, how the disease process works and all the nuance. So we have to be able to coach them but also informing them. So I tell them, I hope that you leave this conversation with nearly as much information or knowledge that I know. Because again, every patient's going to want something different. But if we can leave a patient alone and let Mr. Jones live out the remainder of his life the way he's supposed to and the way he is right there and then, that's the win. So we have to identify which are the prostate cancers that are going to be the bad actors and which are going to be the good actors. So for me, if I can keep a patient on active surveillance for life, that's my ultimate goal. And I'm a surgeon. And so if I need to operate, then, we'll certainly pull the trigger on the right patient. But I don't want to do it for the patient who, doesn't have the actual clinical indications. So yes, just going back to the patient care trifecta, I want to control his prostate cancer. I want to control his urinary continence and leave that the way it is. And I want to make sure that they are happy with their potency in whatever form that is. So if it's, you know, active surveillance or surgery, I want to do the right treatment for the patient for the right reasons.
Yeah, absolutely. And one of the things that stuck with me in our last conversation was each patient is a little different. Some of those, areas in the trifecta matter more to them than others. And so taking that into account with the shared decision making is so important. So that's great. We have a couple questions in the chat. The first one that came in was, how did you decide on a cutoff of 30?
So if you look at Vip Patel's data, if you kind of dive into his the specifics, actually, I can go back here. Um, give me a second. So if you look here, so the quartiles are broken so that the first and second quartile, it's like 15 and then 30. So greater than 29. So it was really, 30 is where you saw 30 and above is where you start to see higher risks of EPE, seminal vesicle invasion, and surgical margins. So it was really based on this study, and it was nice to hear him present on that in the previous webinar. And if we have that available to the audience, we can provide that as well, because I think it'd be nice to hear that.
Absolutely. Yes, we're getting ready to post it available for everybody on the website. So, yes, keep your eyes out for that. We'll also announce it on social media. So, um, not to put a plug in, but follow
Yeah.
us on social media and you'll see when it comes out. Okay,
Sorry,
that's
they say
yeah,
GPS of 29. I use 30 just to finish that thought. I use 30 because 30 is a round number and it's just easier than 29. So,
great. Okay, next question. Do you have any experience with risk stratifying a PIRADS 3 lesion using ExoDX?
risk stratifying a PIRAS 3 lesion. No, so my utilization of ExoDX is whether or not to pull the trigger on a biopsy. That's been, my treatment paradigm for ExoDX. I would love to hear if anybody else has any other experience, but really for me, it's helping me identify who I can avoid a biopsy on and who I should feel a little bit more concerned about and pull the trigger on doing a biopsy.
Right, next question. What parameter is the decision maker for you? The total GPS score or the percent risk of non-organ confined disease or adverse pathology on radical prostatectomy?
Amazing question. I love that. So let's look at one of the. So I kind of look at all of it, and I actually print this out and I hand it to the patient, and then I also copy and paste it and put it in the chart. So, in my electronic record, I post this. So all of them are important, but again, I kind of remove the long-term mets and death because prostate cancer, as we know, very long time to met out and cause disease-specific mortality. And so again, more germane to this patient population are the adverse pathology. So non-organ confined disease for me is probably the most important thing. High-grade disease less so because even for grade group 4 disease and low volume grade group 5, we can operate on those patients and cure them if they're locally, if it's still localized. So it's really that non-organ confined disease percentage that has me concerned. So I tend to use the overall GPS score and non-organ confined disease percentage. And then I would say third on my list would be the likelihood of adverse pathology when I look at the color schema, the low, moderate, and high likelihood. Because that, when I'm counseling a patient, that resonates with them.
Absolutely.
And
Okay, we
again,
have another.
these might be a
Oh,
little bit outdated. There are new schematics that are coming
yeah.
out, and Denai, you can speak to that. But
Yeah.
this was maybe a little bit of an older iteration.
Yeah, it's the original, right? No, so we do have some new updates to the report. The information within it hasn't really changed, but we have actually taken those endpoints and moved them up higher on the report so they're more visible instead of being on a back side of the page. But yes, those are rolling out as we go. We have another question that came in. Did you say you do repeat GPS testing? And if so, what marker do you use to decide to redo the GPS?
So for all of my restaging biopsies, if they're going to stay on active surveillance, I'll repeat the GPS. Now, if I've gotten to like three biopsies and it's stayed biologically the same, then I actually just largely I'll just follow the PSA. And I won't even keep doing biopsies at some point. But for all of my repeat biopsies, I want to see. It was based on a study actually by Peter Carroll, again out of UCSF, and I think Matt Cooper-Berg was on that one. And they looked and showed that serial GPS tests can alter your management. And we can provide that study for the group as well. Maybe we could put the link in the chat. But that study was really valuable for me, and since I've utilized sequential GPS testing on all of my restaging biopsies. So if I'm doing a restaging biopsy, so again, just to get in the weeds here a little bit, very low risk and reassuring GPS. I actually don't do a restaging biopsy until the PSA dictates that something is changing. So I'll hold off on doing a restaging biopsy because I've been reassured by the biopsy and the GPS test. Now, if it's like a true low grade disease, I will repeat the biopsy at probably about 18 months unless the PSA dictates otherwise, and I'm getting GPS again at that point. For grade group 2, I'm probably going to restage them somewhere in the 6 to 12 month range.
I was going to ask you to walk through all of those pieces, but you did it automatically. So that's perfect. Thank you. Next question. I love it. Keep the questions coming. What language do you use when discussing the GPS results with a patient to kind of translate the information, either to support an active surveillance decision or address any level of concern that it might, bring up, especially in some of these cases, for example?
So I love diagrams, and I will pull up a picture of a prostate and show them what it looks like to have a prostate cancer that's within the prostate. And maybe it's a tiny focus. If it's one core, I'll kind of show them the dot. Or if it's starting to creep outside. So when I have the report of GPS and it says 34% chance of non-organ confined disease. Well, to a layperson, that sounds like Charlie Brown, wah, 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 wah. They don't know what
Yeah,
that means.
absolutely.
So I'm showing, I have this diagram of the prostate. I'm saying non-organ confined disease. It's outside of the prostate now. This is your organ, and it's not confined to it anymore. And there's a 34% chance of that happening at the time of your surgery based on this test. So the biopsy that we did, while the pathology is reassuring, when you pop the hood and look underneath at the genetics of it or the DNA, um, then it's showing that this thing may be a little bit biologically more aggressive.
That's great. I like the visual aspect. I think that's a really great way to represent that without using all the technical language. I think that's fantastic.
Yeah.
Okay, next question. Do you only order this for GG1 and GG2? And then additionally, is this done reflexively, or do you counsel the patient about the test and ask if they would like to have it done? So two-parter.
Great questions. Yes, for just GG1 and GG2. Um, I'm not really surveilling grade groups 3 and above, but if a patient, well, no, I would say just GG1, GG2. Um, because, in the past, I may have used it for intensification or de-intensification of ADT, but really I'm using GPS for the active surveillance cohort now, in full transparency. So for all of my low and favorable intermediate risks before they undergo active surveillance, this is the test I'm using. Um, how do I counsel them? So I say that, again, this is good news, but until I understand what's actually happening within the tumor, I can't tell you and completely reassure you. So this test is really important to support, what was shown by our pathologists. And I have great pathologists, by the way. So it's not to any fault of my pathologist. It's just they actually like it because it supports or changes their diagnosis. So I do tell the patient up front that we're going to be ordering it. Um, it is covered by all insurances, including Medicare and Medicaid. Um, and even my patients who are underinsured or uninsured, there are, patient assistance platforms that this company actually is really good at helping them minimize costs.
Yeah.
So, I'll talk to them and make sure they're aware that I'm ordering it. Um, but I have yet to have a patient say they don't want it. So I can't say that I'm giving them a choice. I'm not telling them they have to have it or I'm not going to take care of them, but I really kind of emphasize the importance here.
Yeah. And you have that a conversation, it sounds like up front as well.
Yeah,
So it's not a surprise on the back end if it does. So
right.
if they did have concerns, they'd be able to address any of those at the start.
Yeah, sorry, and I didn't address part of the question about reflex. I would if I could.
Yes.
It would make my life so much easier, because then I wouldn't have to like put the sticker on and do the thing. I have an amazing rep, so she really helps make my life easier. But if I could have it be a reflex, I would. Unfortunately, I work in a public hospital system that doesn't allow me to reflexively order tests like this.
No, thank you. And also to clarify, we do work with most insurance carriers. I don't know if we work with all of them, but we do have a really great patient value program. We want to make sure people have access to testing, so we do what we can to make it affordable for everybody. Um, okay, I think, does anybody else have any other questions? I did put the active surveillance study in the chat for anybody who would like to take a look. So it takes you to PubMed, and you can go check that out. But in the meantime, we'll pause for a second before I start my closing. Thank you all for your time this evening, and thank you, Dr. Weiner, for sharing your experience with use in this active surveillance population, and also providing some really great examples of how it actually helps with those treatment decisions, whether it's escalating to surgery or keeping them on active surveillance for as long as you can. Before we close, we do have a brief survey. I'd like to ask if you could be willing to take it. It's less than 5 minutes, so it won't take very long. It's only a few questions. We're trying to gather feedback on how we can simplify information to improve patient understanding. It's really important to us not only that the testing is accessible and available to the providers, but also to the patients you serve. We want them to understand why they're getting a genomic test and how it's helping their provider or them help make decisions in general. So your insight is invaluable and would help us enhance the value GPS can provide your practice. You can either complete the survey immediately following closing of the Zoom webinar. We'll also send a follow-up email. So if you don't want to deal with it tonight because it's late and it's bedtime, if you're on the East Coast or past bedtime, you can take it at your leisure. But we appreciate your responses. We appreciate everyone's time this evening. Thank you so much. Have a really wonderful night. Good evening.
Thanks, everybody. Good night.